Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently GR2 in the Department of Pharmacology, AIMS Kalyali, and I am back with one of my seminars again. So without wasting any time further, let's get into today's video. So in today's video, I'm going to deal with the topic that is screening of drugs for hypertension. So this topic will be covered under the following headings, that is the introduction to it, then the principles of anti-hypertensive therapy, current lacunae in the pharmacotherapeutics, that is for hypertension, that is what is the current lacunae, then the methods of screening, under which we are having different methods, that is in silico methods, that is computer based methods, then in vitro methods, and then in vivo methods, which is the main focus of today, that is basically the animal models, and then some of the take home points. So let's begin with the introduction. So hypertension is the most common cardiovascular disease, and it is characterized by elevated arterial blood pressure, which causes hypertrophy of left ventricle. Then it also causes pathological changes in vasculature, and this hypertension has a tendency to cause other diseases also, like that is the end organ damage, that is when it causes left ventricular hypertrophy. As you can see here, this is one of the problem, that is cardiovascular risk, which is associated with hypertension. Along with that, it can cause coronary artery disease, that is in the form of myocardial infarction, in the form of stroke, in the form of transient ischemic attack. Then it can also lead to dissecting aneurysm of aorta, because there is elevated blood pressure inside the aorta. Then it can also lead to renal insufficiency. So all these are basically the complications of hypertension, and hence it is necessary to treat hypertension basically, and the prevalence of hypertension increases with age. And so we can decrease this prevalence by the following measures, that is by frequently updating the guidelines for the management of hypertension, promotion of a single pill combination therapy for hypertension, then doing regular check of the blood pressures, that is in the follow-up visits. Apart from this, what we have to do is we have to also do electronic tracking of the individuals and take regular feedback from the providers. And apart from this, we are also going to do evidence-based treatment. That is, evidence-based treatment is basically the best method of doing the treatment right now for any sort of disease. So what we have to do to decrease the prevalence of hypertension is that we have to follow the latest guidelines of treatment. We have to promote the use of single pill combination therapies. We have to do the check of blood pressure in the follow-up visits, and we have to continuously keep a track of the patient who is suffering from hypertension. That is, we can also do the investigations to check whether the individual is developing any end organ damage, as I have already mentioned here, like left ventricular failure, which can occur because of hypertension, persistent hypertension. So whenever an individual is having high BP, that is hypertension, okay, along with that, if the individual is having some of the end organ damage, okay, end organ damage, then in that case the prognosis is going to be worse compared to the prognosis where the individual is having only hypertension and no end organ damage. So examples of end organ damage, for example, it can be in the form of retinal hemorrhages, in the form of papilledema. So these are the findings which we can see in the eyes, okay. Apart from this, in heart, what we can see left ventricular hypertrophy in electrocardiogram. Then we can see renal insufficiency by altered renal function test values, that is basically the serum creatinine and serum urea values. So all this will indicate the presence of any end organ damage, and whenever there is hypertension along with the end organ damage, the prognosis is worse compared to hypertension alone. And the risk of cardiovascular disease, all these diseases which are occurring along with hypertension, that increases when the individual is doing cigarette smoking concomitantly along with hypertension, or if the individual is having other comorbidities like diabetes or elevated low density lipoprotein. So all these will increase the chance of development of end organ damage in hypertension patient, and as a result that will lead to worse prognosis. So why to treat hypertension? So I have already mentioned that the purpose of treating hypertension is basically to decrease the cardiovascular risk and to improve the life expectancy. So what happens is, when we do effective pharmacotherapy for hypertension, it decreases the morbidity and mortality from cardiovascular disease. Particularly, it also decreases the risk of stroke, heart failure, and coronary artery disease in the form of myocardial infarction. So all this will decrease when we are doing prompt pharmacotherapy of hypertension. Now, coming to the principles of anti-hypertensive therapy. So, non-pharmacological therapy, that is basically the lifestyle-related changes, it is used as an important component for the management of all the patients of hypertension. That is, in some grade 1 hypertensives, the blood pressure may be adequately controlled by the combination of all these lifestyle modifications only. So there we don't even need the use of pharmacotherapy. So what are these lifestyle modifications? First, if the individual is overweight, in that case we have to achieve weight loss. Then we have to restrict the sodium intake, that is to less than 5 gram per day. We have to do increased amount of aerobic exercise, that is more than 30 minutes per day. Then we should moderate the consumption of alcohol, that is it should be less than 2 drinks in men and less than 1 drink in women, that is basically 20 to 30 gram in case of men, less than 20 to 30 gram in case of men, and in case of women it is 10 to 20 gram of alcohol, less than 10 to 20 gram of alcohol in case of women. Okay, then smoking cessation is to be achieved. Then increase consumption of fruits and vegetables and low fat dairy products. Okay, so all these are basically the non-pharmacological, that is the lifestyle related changes which can be used for the management of hypertension. In some of the grade 1 hypertensives, we don't even need the use of pharmacotherapy, but if the stage progresses, that is the grade progresses, then we need to use the pharmacotherapy. So the current guidelines from different cardiovascular societies, what they say is that they have to use a single pill combination therapy as the pharmacotherapy, that is the starting thing. Okay, so most of the patients usually require drug therapy for BP control, that is grade 1 hypertensives are less in number. So in all the individuals, most of the cases we will require the pharmacotherapy. Along with that, we will require the dietary modifications. Now let's continue with this. So as we know that blood pressure is the product of cardiac output and peripheral vascular resistance. So the drugs which are used in pharmacotherapy of hypertension can act by lowering the BP, that is it can do that by either acting on the peripheral vascular resistance or by acting on the cardiac output or by acting on both peripheral vascular resistance and cardiac output. So drugs which decrease the cardiac output, they act by either inhibiting the myocardial contractility. Okay, so that is one way. Then they can also decrease the ventricular filling pressure. And how do they do that? That is by decreasing the venous tone. So this basically causes venodilation and stasis of blood, and as a result the blood doesn't reach the heart, so there is decrease in the cardiac output, that is the blood which is being filled in the ventricle is less. Then by decreasing the blood volume by renal effects, that is basically the drugs which act on the renin, angiotensin, aldosterone system. Then we have the drugs which decrease the peripheral vascular resistance. So what they do is they interfere with the systems that produce the constriction of blood vessels. So what are those systems which causes constriction of blood vessels? One is the sympathetic nervous system, and next is the renin angiotensin system. That is, in renin angiotensin system we have the angiotensin 2, which are actually having the vasopressor activity. So these drugs will act against these systems, that is they are actually going to be sympatholytics. So that is how we cause the decrease in the peripheral vascular resistance and hence get the antihypertensive therapy. So it is recommended that we do concurrent use of drugs from different classes of antihypertensives to achieve effective control of BP while minimizing the dose-related adverse effects of one particular group of drug. That is, if we use only one particular group of drugs, then we will have to give a larger dose, that is, we have to give a higher dose of that particular drug, and also there will be increased chance of adverse effect also in that case. But if we give combination of two to three different classes of drugs in a single pill, then the blood pressure will be decreased by different mechanisms. So in that case, we don't have to give an increased dose of a particular drug, and as a result, there will be less chances of dose related adverse effects of any group of drug which is a part of that combination in the combination pill. So that is the advantage of using a single pill combination therapy for the management of hypertension. Now, as you can see here, in individuals, so what are the interventions which we have to do? So in individuals, that is where the individuals who are having normal BP, that is less than 120 to 80 mmHg, in that case, we have to promote optimal lifestyle habits. That's it. That is, we are the lifestyle changes which I have already mentioned, and then we will reassess the individual after 1 year. That is, at every 1 year we are going to reassess the individual. Suppose if the individual is having elevated BP, that is systolic BP 120 to 129 and diastolic BP is less than 80 mmHg. In that case, we will go with non-pharmacological therapy, that is the lifestyle modifications, and then we will reassess the patients for the control of the blood pressure at every 3 to 6 months. Then, if the individual is a stage 1 hypertensive, that is the systolic blood pressure is 130 to 139 and the diastolic blood pressure is 80 to 89 mmHg, then in that case, we will look for one more parameter, that is if there is any presence of clinical ASCVD, that is atherosclerotic cardiovascular disease, or if there is an estimated 10-year cardiovascular risk which is more than equal to 10% in that individual. And if we get the answer to this question as no, then again we will be giving non-pharmacological therapy, and then we will reassess the individual at 3 to 6 months. If we get the answer yes, that is the presence of cardiovascular disease or cardiovascular risk more than 10% in the next 10 years, then in that case we will have to start non-pharmacological therapy, that is the lifestyle modifications plus the BP lowering medications, that is antihypertensive basically. And then we will reassess after 1 month. Suppose if we get the BP goal, that is the required BP, then in that case now we will start reassessing the individual at 3 to 6 months. And if we are not getting the desired BP control, then we are going to optimize the adherence to the therapy, that is the therapy which is given to the individual right now, and we will consider the intensification of the therapy also, that is we will add other antihypertensives to the treatment regimen. Okay, so if the BP goal is met, then again we will go back to reassessment at 3 to 6 months. If the BP goal is not met, then we have to do the intensification of the therapy, and we have to check whether the individual is properly adhering to the treatment or not. So this is about stage 1 hypertension. Now coming to the stage 2 hypertension, that is blood pressure of more than equal to 140/90 mmHg. So here directly we are going to start with non-pharmacological therapy plus BP lowering medications, and then we are going to do the reassessment at 1 month, and next it is the same thing, that is if the BP goal is met, then we will reassess at 3 to 6 months continuing the medications, and if the BP goal is not met, then we are going to check for adherence first, that is whether the individual is adhering properly to the medications which he or she was given earlier. And suppose if the adherence is proper, and then we have to do the intensification of therapy, that is adding other antihypertensive classes to the current treatment regimen. So intensification is done later on. So this is in whole how we are going to manage the individuals, that is based on the stage of hypertension, that is whether they are stage 1 hypertensive, stage 2 hypertensive, whether they are having any risk of cardiovascular disease. So based on that, we are going to choose whether we are going to give non-pharmacological management alone or non-pharmacological management plus the antihypertensive therapy, that is the drugs which lower the BP. Now as you can see here, so initial combination therapy which we are giving is basically a dual combination therapy. Okay, so here we are going to give a single pill which is going to have the following drugs, that is ACE inhibitors, angiotensin converting enzyme inhibitors or angiotensin receptor blockers, plus CCB, that is calcium channel blocker or diuretics. So what we are going to give is either ACE or ARB plus CCB or diuretic. And we can consider monotherapy only in case the individual is a low risk grade 1 hypertension, or if the individual is a very old patient and frail patient, that is more than 80 years of age, because in that case the individual might not be able to tolerate the multi-drug regimen, that is a combination of two drugs in a single pill. Then in step 2, suppose if it is not getting control, then we are going for the triple combination in a single pill. So here we can give ACE or ARB plus CCB plus diuretic. So what was the first thing? That is either we are going to give CCB or diuretic, but here we are going to give both CCB and diuretic, and option is there for angiotensin converting enzyme inhibitors or angiotensin receptor blockers. So in this we are basically going to decide based on the type of adverse effect. Suppose if the individual is developing any edema or cough following the administration of angiotensin converting enzyme inhibitors, then in that case we are going to switch the individual to angiotensin receptor blockers. Now coming to the next step, that is suppose if still there is no improvement, then we are going to go for the step 3, that is triple combination plus spironolactone or other drugs. So here we are going to use 2 pills. Okay, so this is basically resistant hypertension. What do we mean by resistant hypertension? That is, according to WHO, if the individual is not showing any response when we are going to give these 3 classes of the drugs with their maximum dose, okay, and in that one drug should be diuretic. As you can see, one drug is diuretic. Then in that case we call it as resistant hypertension, and then we are going to add other drugs to it like spironolactone. We can add spironolactone, or we can also add other diuretics or alpha-1 blocker, or we can also add beta blockers. So we can consider beta blockers at any treatment step if there is a specific indication for their use. For example, if the individual is having heart failure, if the individual is having angina, if the individual is a post-MI patient, that is post-myocardial infarction patient, if the individual is having atrial fibrillation, or if it is a younger woman with or planning of pregnancy. So if any of these is present, then we can add beta blockers at any stage, basically at any of the stage, the step 1, step 2, step 3. And also ask the individual in step 3 to go and meet the specialist, basically to find out what is the cause of hypertension in that individual. So this is in whole how we are going to manage, like how we are starting the therapy and how we are escalating the therapy when we are not going to get the response, okay, and how we are going to manage the resistant hypertension. So all those things I have covered. Now let's get into the different types of the targets which we are having for the antihypertensives. So it is basically the similar thing which I have already discussed, like either it will be the drugs which are going to decrease the cardiac output, or it will be the drugs which are going to decrease the peripheral vascular resistance. Overall it leads to decrease in the blood pressure. So as you can see here, so here we will see different drugs and their different targets. Okay, so heart, it is responsible for generating the pressure. So here we are having this yellow dots. Yellow circles are basically the sensors which are sensing the pressure. So if there is increase in the blood pressure, then it goes and acts on the brain, that is where we are having the central control for modulating the blood pressure. And from brain only we are getting the sympathetic nervous control, which is actually responsible for causing increase in the blood pressure, that is via the neurotransmitter, that is norepinephrine. So here we are having one drug, that is beta blocker. So beta blocker, basically if we are using a beta 1 blocker, so the beta 1 receptors are present in the heart, so it will decrease the contractility of the heart. So this is one of the antihypertensive medication. Next we are having alpha 2 adrenergic agonists like methyl dopa, which is acting at the central level. That is alpha 2 is basically a presynaptic receptor. So what it does is, like as you can see, suppose this is the synapse, so here we will have the alpha 2 receptor. So whenever alpha 2 receptor is being stimulated, what it does, it causes decrease in the release of the norepinephrine or the neurotransmitter from the presynaptic neuron to act on the postsynaptic neuron, and as a result again we will get antihypertensive effect, that is decrease in the blood pressure. Now coming to the next set of drugs. So if we decrease the salt consumption in the diet, that is salt reduced diet, okay, then there will be decrease absorption of salt and water from the gut. As a result there will be decrease in the blood volume, so this will decrease the blood pressure also. So this is one more method. Then we have the drugs which are mainly acting on the renin angiotensin aldosterone mechanism. So as you can see here, in kidneys there is salt and water excretion, okay. So here we are having angiotensin converting enzyme inhibitors and angiotensin receptor blockers. So whenever there is angiotensin, okay, like angiotensin 2, it is actually responsible for causing the release of aldosterone from the adrenal gland, which is present above the upper pole of kidney. So if we give angiotensin receptor blockers or ACE inhibitors, then there will be no production of aldosterone. As a result, there will be no sodium and water retention. So this will lead to decrease in BP. Then we can also use mineralocorticoid receptor antagonists like spironolactone and other diuretics, which will cause the release of more fluid out of the body, as a result decreasing the blood volume, leading to decrease in the blood pressure. Okay, then angiotensin receptor blocker will also decrease the peripheral resistance, that is because angiotensin 2 is a vasopressor in nature, so as a result it will decrease the vasoconstriction when we are giving angiotensin receptor blocker. Then we have the next group of drugs, that is CCB. So that is calcium channel blocker. So it basically decreases the constriction of the blood vessels. So as a result, again, it will decrease the blood pressure. So these are all the different targets on which we have the antihypertensive drugs, where the antihypertensive drugs act. And then we also have endothelin receptor antagonists like aprocitentan, because endothelin is also responsible for the pathological features and pathophysiology and the development of the end organ damage in case of hypertension. So this is one of the latest drug, that is aprocitentan. Now coming to the lacunae in current pharmacotherapeutics of hypertension. So addressing the underlying causes of hypertension is very important. Okay, so current medications, what they are doing is they are primarily focusing on lowering the BP only. But further research is needed to develop the treatments that address the underlying cause of hypertension, because by just doing the symptomatic management, it is not enough. We need to treat the underlying cause. So that is one important lacunae. Then resistant hypertension, we have to develop newer drugs for resistant hypertension. According to World Health Organization, resistant hypertension is defined as high blood pressure that remains above the target level despite taking 3 different classes of antihypertensive medications at their maximum tolerated dose, and one of them should be a diuretic, as I have already mentioned in the treatment algorithm. Then when the resistant hypertension develops, then we are going to start with spironolactone or other diuretics or alpha blockers or beta blockers, and we are also going to refer the individual to the specialist so that they can find out what is the cause of this resistant hypertension. Then some of the drugs were initially developed for the treatment of conditions which are different from hypertension, including heart failure and diabetes. Okay, but now they have demonstrated that they are also having significant BP lowering effect. So we need to do further research in this field so that we can also use some of the other drugs which are approved for other conditions for the management of hypertension. Then the newer antihypertensive drugs which we are going to develop in the upcoming future will improve the hypertension treatment by offering the following advantages, that is they will be more targeted, that is they are having more targeted mechanism of action, that is they will act on a particular receptor, they will have less side effects, they will have improved patient adherence, and apart from that they will also provide additional benefits of organ protection, because as you know, in hypertension, when the hypertension is present for a long duration of time, it can lead to several end organ damage like left ventricular failure, renal failure, some changes in the eyes, and several changes like left ventricular hypertrophy also. So all those things. So this is the reason why we need to do continuous research for the development of the new antihypertensives. Now for this we need to do the screening of the drugs for hypertension. So the different methods of screening, broadly we are having 3 methods, that is in silico methods, then we have in vitro methods, and then we have in vivo methods. So our main focus will be on the in vivo methods. Okay, so first in vitro method, what we are going to do, in silico method is basically computer based methods, so that I am going to discuss in the upcoming slides. Then we have in vitro method. So in vitro methods we are having 2 models, that is endothelin receptor antagonism in porcine isolated hearts. So basically we are going to take the coronary arteries from the porcine heart, and then we are going to check the effect of the antihypertensive on that artery. Then we have monocrotaline induced pulmonary hypertension. So these are the 2 experiments which are coming under in vitro models. Then in vivo models we are having rat models, we are having dog models of hypertension, we are having monkey models of hypertension, and we are having transgenic model of hypertension also. So rat models, we are going to discuss that broadly and in a total detail. So under this we are having renovascular induced hypertension, then we are having neurogenic induced hypertension, then we are having diet induced hypertension, then we are having endocrine induced hypertension, then we have psychogenic hypertension and genetically induced hypertension. So under renovascular induced hypertension we are having three different models. First is gallbladder hypertension model, that is basically 2 kidney 1 clip model, and then we are having chronic renal hypertension in that model, that is 1 kidney 1 clip method. Then we have again another method for inducing chronic renal hypertension in the rats, that is 2 kidney 2 clip method. So I am going to discuss all these methods, that is the 2 kidney 1 clip method, then we are having 1 kidney 1 clip method, 2 kidney 2 clip method. So all the three I will be discussing in the upcoming slides. Now in case of neurogenic induced hypertension, so it is basically inducing hypertension with the help of breathing, that is it is observing the blood pressure changes in the pith head rats. Then we have the diet induced hypertension, so it can be either fructose induced hypertension or it can be due to increased salt intake. Then we have endocrine induced hypertension, that is DOCA salt rats, that is basically deoxycorticosterone acetate. Then we have the psychogenic hypertension, so here we are inducing hypertension by doing the air jet stimulation on the rats, that is basically torturing the rats with the air jet. Then we are having genetically induced hypertension, so under this we are having salt sensitive, under this we are having dull salt sensitive rat, and we are having spontaneously hypertensive rats. So in that hypertension is occurring on its own, we don't have to induce hypertension in them. Then in dog models of hypertension we are having chronic renal hypertension model, and then we have neurogenic hypertension models. Then monkey model of hypertension is mainly for the test of antihypertensive efficacy of renin inhibitors, that is renin inhibition in monkeys. Then transgenic model of hypertension, so here we have transgenic rats overexpressing the mouse ren2 gene. Okay, so we are going to introduce this mouse ren2 gene in the rat's genome, and as a result it will lead to hypertension. How? I am going to discuss that in the upcoming slides. Okay, so in short, these are the different models which are used for the screening of drugs for hypertension. Now let's discuss one by one these methods. First, coming to the in silico methods. So the in silico methods, under this the main techniques which are used are virtual screening, then we have molecular docking. Okay, following virtual screening we are having molecular docking, then following molecular docking then we are having QSAR, that is quantitative structure activity relationship. Then from there we are going to pharmacophore modeling, then ADMED prediction, that is absorption, distribution, metabolism, excretion and toxicity prediction, and then finally we are having molecular dynamic simulations. So these all methods are common to almost all types of drugs, like all the types of drugs, whether it is antihypertensive, whether it is anti-diabetic. So this is in general same for almost all the drugs. So what we do in virtual screening is basically we are going to sift through a library of molecules, and we are going to find out potential drugs which can become antihypertensives. So what we are going to do is we are going to test millions of chemical compounds in a virtual environment to see if they can bind to specific targets such as proteins which are involved in hypertension, like angiotensin converting enzyme, then we have angiotensin receptors, then we have mineralocorticoid receptors. So all these are the targets to which if a drug or a molecule binds, then that drug can have an antihypertensive effect. Then after this, what we are going to do is we are going to do molecular docking. So molecular docking, this simulates how a drug molecule, that is ligand, interacts with its target, that is receptor or a protein. That is basically it predicts how tightly and specifically the particular molecule which we have selected from virtual screening is going to bind to the hypertension related protein. That is how tightly it binds to the angiotensin receptor, how tightly it binds to the angiotensin converting enzyme, how tightly it binds to the mineralocorticoid receptor, how tightly it binds to the endothelin receptors. So all the different types of receptors and the target proteins to which the molecule which we have selected from the virtual screening, how tightly it binds to those receptors. Then coming to the next step, that is QSAR, that is quantitative structure activity relationship. So this uses math and statistics to predict how effective a molecule will be based on its chemical structure. So basically what it does is it correlates the molecular features like the size, shape, charge with their biological activity, and here the biological activity is the activity to decrease blood pressure using maths and statistics. Okay, then following this we are going to do pharmacophore modeling. So this basically creates a 3D map of features required for a molecule to bind to its target is basically the proteins or the receptors which are involved in the pathogenesis of hypertension. And then we are going to do admit prediction, that is whether the molecule which we have found after all this process, that is virtual screening, molecular docking, QSAR, pharmacophore modeling, whether it is suitable for use in the individuals, whether that is it is having proper pharmacokinetic features, whether it is tolerable, that is whether it does not cause toxicity in the individuals, unacceptable toxicity. So that is being checked by this admit prediction. And finally coming to molecular dynamics simulations, where we are simulating how the drug behaves when it binds to the protein, that is in realistic conditions, that is at body temperature. So that is basically the realistic situation, because we are going to give the drugs to individual at their body temperature. So that is what is meant by molecular dynamics simulations. So this is in whole about the in silico methods. Now let's discuss the workflow. So as we have already discussed, it is basically first to find the target, then build a virtual library. That is, in that case we are going to find all the different types of molecules which are going to bind to this target. Then we are doing the virtual screening out of it from the library. Following that, we are going to do molecular docking, that is how tightly and specifically that molecules which we have selected from virtual screening are binding it, and then we are narrowing it down further. That is, we are decreasing the number of molecules. As we go down the process of in silico screening, the number of molecules keeps on decreasing. Then we are going to do the QSAR analysis, okay, using the maths and statistics. Following that, we are going to do pharmacophore modeling, and then we are going to do the admit testing, that is whether it is having a proper pharmacokinetics and whether it is not going to cause toxicity. And finally molecular dynamics, that is molecular dynamics simulation is being done under realistic conditions like body temperature. So all this is being done in the computer. So that is the reason why it is called as in silico screening, and it is almost the same for all the different types of drugs, whether it is anti-hypertensive, whether it is anti-rheumatic drugs, whether it is anti-diabetic drugs. It is almost the same. Overall the process remains the same. So now coming to the in vitro methods, which is specific for the drugs which are used for hypertension. So in this we are having two models. First is endothelin receptor antagonism in porcine isolated hearts, and then we have monocrotaline induced pulmonary hypertension model. So let's discuss this one by one. So first one is endothelin receptor antagonism in porcine isolated hearts. So potent long-lasting contractions of isolated blood vessel strips and increased blood pressure in vivo is elicited by endothelin peptides. So that is why we are using endothelin receptor antagonist for the management of hypertension. So in this model, what we are going to do is we will take the left anterior descending coronary artery from the porcine hearts, that is basically the big hearts, that is they are isolated, and from that we are going to cut spiral strips, that is from that left anterior descending coronary arteries we are going to cut spiral strips of about 10 mm long, that is 10 mm in length and 1 mm in width, and then each strip is suspended in an organ bath which is containing the KH solution, that is Krebs Hensley solution, which is bubbled with 95% oxygen, 5% CO2 at 37 degrees Celsius. Then we are going to add endothelin 1 to this, that is basically which is responsible for causing the contraction or the vasoconstriction of the blood vessels, and then the contraction of the strip is being noted. Then later on we are going to add endothelin 1 also, and endothelin receptor antagonist or the test compound, that is the compound which we are thinking can become a potential antihypertensive in the upcoming future by acting against the endothelin 1 which acts on the endothelin receptor, and then again we are going to see the contraction of the blood vessel. So if the contraction decreases, it means that the drug which we are giving, that is the drug which we are thinking to be an endothelin receptor antagonist, is acting against endothelin, and it is now binding to the endothelin receptor, not allowing endothelin 1 which is responsible for causing the vasoconstriction to bind to the receptor. And we will also check the change in the intensity of the contraction to see the antihypertensive effect of this endothelin receptor antagonist or the test compound. So this is about the endothelin receptor antagonism in porcine isolated hearts. So from porcine hearts, we are going to take the coronary artery, then it is being cut into several strips. It is suspended in the Krebs Henlet solution, which is being bubbled with 95% oxygen and 5% CO2 at 37 degrees Celsius. Then we will give the vasoconstrictor, that is endothelin 1 here, and we will note the contraction. After that, along with this, we are also going to give the endothelin receptor antagonist or the test compound which we think have endothelin receptor antagonistic property, and then again we will note the contraction. If the contraction decreases, then we will see by how much the contraction is decreases to look for the antihypertensive effect of the test compound. So this is about the endothelin receptor antagonism in porcine isolated hearts. Now let's discuss the next one, that is monocrotaline induced pulmonary hypertension. So monocrotaline is basically a hepatotoxic and a pneumotoxic agent, and that is the reason why it causes pulmonary hypertension in the rats. That is, when we want to induce pulmonary hypertension, we can give monocrotaline to the rats. So in this, what we are going to do is we are going to take the Sprague Dolly rats 200 to 225 gram in weight, and they are fed with the test drug, that is the drug which we are thinking is going to have the antihypertensive property, for 1 week prior to single subcutaneous injection of 100 milligram per kg of monocrotaline. Okay, so we are going to give the antihypertensive medication, that is the medication which we are thinking is going to be a potential antihypertensive, for 1 week prior to the single subcutaneous injection of monocrotaline, that is 10 milligram per kg dose, and then the animals, that is the rats, are sacrificed at 4, 7 or 14 days later, and from those animals the pulmonary artery segments and main pulmonary arteries are isolated, and then each vessel is suspended between two stainless steel hooks in a tissue bath containing the KH solution, that is Krebs Henlet solution, and aerated with 95% oxygen and 5% carbon dioxide at 37 degrees Celsius. And after 1 hour, what we are going to do is we are going to see the contractile and the relaxant agonist responses in these pulmonary artery segments. Using the different agents, we can use KCl for contraction, we can use angiotensin 2, we can use norepinephrine also. So this is going to check basically the antihypertensive effect of the drug which was given for 1 week prior to the administration of the monocrotaline. And when we are giving vasoconstrictors, when we are giving the vasopressors like KCl, angiotensin 2 and norepinephrine, we will see how effectively the drug which was given is contradicting their action and also contradicting the action of monocrotaline, because monocrotaline is also responsible for causing pulmonary hypertension in rats. So this is about the second in vitro model. Now coming to the in vivo models, which is the main focus of this presentation. So under this we are having rat models of hypertension, then we have dog models of hypertension, then we have monkey models of hypertension, and then we have finally the transgenic models. So first let's discuss the rat models of hypertension. Under this we are having variety of models. So first it is renovascular hypertension. So what is this renovascular hypertension? Like how hypertension occurs based on this principle, that is the renovascular hypertension. So what we are seeing here is a flow chart. So as you can see, whenever there is decrease in the blood pressure, that is normal physiology, there will be release of renin from the kidneys, and then what renin does is it converts angiotensinogen, angiotensinogen to angiotensin 1, and then this angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme which is present in the lungs, and this angiotensin 2 is responsible for causing the vasoconstriction. As a result, it leads to increase in the blood pressure. Then angiotensin 2 also acts on the adrenal gland and it leads to the release of aldosterone. So it causes sodium and water retention, which increases the blood volume, and as a result again it increases the blood pressure. So whenever there is decrease in the blood pressure, renin is being released and the end product is increase in the blood pressure. It can be either due to vasoconstriction due to angiotensin 2, or it can be due to sodium and water retention which is caused by aldosterone following the stimulation of adrenal glands by angiotensin 2. So if we are targeting this and we are inducing hypertension, this pathway, and if we are inducing hypertension in the rats, then it is called as the renovascular hypertension, under which we are having different models, 3 models basically, that is 2 kidney 1 clip model, which is also called as gold black hypertension. Then we have chronic renal hypertension, that is 1 kidney 1 clip method, and then we have 2 kidneys, 2 clip method. So clip means basically the occluder. So basically we are going to put a clip in the renal artery, and we are going to occlude the renal artery. As a result, there will be decreased supply to the kidney. So the kidney will think that there is decreased blood flow, so it will be mimicking decrease in the blood pressure, and as a result there will be increased production of renin. It will also cause activation of the sympathetic system also. Like whenever there is decrease in the BP, that is decrease in the blood flow to the kidney, it will cause increased production of renin, and it will also cause activation of sympathetic system. So initially there will be rise in the blood pressure because of this sympathetic system, but renin will not be out because we have clipped the renal artery. So whatever renin is being produced, it is not going into the circulation. As a result, these steps will not occur. So later on, when we remove the clip after some days or after a few hours or some days, then there will be sudden increase in the release of renin, which will lead to development of acute hypertension. So that is basically the principle for producing hypertension, that is inducing hypertension by this method, that is renovascular hypertension. Now let's discuss these 3 methods in detail. So first we have the 2K1C model. So in this, what we are going to do is basically constriction of only one renal artery is carried out with the help of a PVC coated clip, that is polyvinyl chloride clip, while the contralateral kidney is left intact. That is, in the contralateral kidney we are not going to put the clip in the renal arteries, and this is done in Sprague Dawley rats 300 gram in weight after giving them anesthesia. Then what happens is, because there is decreased blood flow to the kidney, this activates the RAS, that is renin angiotensin system, and the sympathetic system also. So later on, this leads to increase in the blood pressure due to the latter. Latter means the sympathetic system. Why? Because the renin is being produced now, but renin is not coming out because the clip is kept intact and it is occluding the renal artery. So now what we are going to do is we are going to remove the renal arterial clip. Okay, renal arterial clip is being removed, leading to release of renin in the bloodstream. So there is suddenly an increase in hypertension, that is increasing the blood pressure, causing acute hypertension. Okay, and the test compound is given, that is the antihypertensive, the drug which we are thinking is having the antihypertensive property. It is given IV by the jugular vein in the rats, and BP is monitored using a transducer connected to the carotid artery. That is basically the direct monitoring of the blood pressure, because it is an invasive method. Basically the catheter is being placed, an indwelling catheter is being placed inside the carotid artery. So what we will see is that when we are monitoring the BP from the transducer which is being present in the carotid artery, we will see there is an increase in the blood pressure after reopening of the renal artery. That is when we are removing the clip, and then there will be reduction of BP following the administration of the test compound IV by the jugular vein. And this is basically compared, that is the pre-treatment BP and the late treatment BP, and this is basically compared, that is the pre-treatment BP and the post-treatment BP, and the change so as to find out the antihypertensive efficacy of the particular drug. As you can see here we have put a clip. Okay, so basically this is a diagram which I have made, and in the renal artery of one of the kidneys of the rat, and following that, after that we are removing it. Okay, and we are noting the blood pressure, so blood pressure is raised. Okay, so then we are going to give the antihypertensive through the jugular vein, and meanwhile we will be continuously monitoring the blood pressure by the transducer which is present in the carotid artery. So we will get a decrease in BP after we give the antihypertensive from the jugular vein. So this is basically the 2K1C model of renovascular hypertension. Now let's discuss about one kidney, one clip method for chronic hypertension. Next 2 models will be for chronic hypertension only. So in this one clip, that is one kidney and one clip model, we are having the Sprague Dawley rats ranging from 200 to 250 gram in weight. So here also we are going to do constriction of the renal artery on one side using the U-shaped silver clip, and on the other side the contralateral kidney is removed. Okay, so on one side we are just occluding the renal artery, and the other side we are removing the kidney. So now the rat is having one kidney and one clip. Okay, the kidney which is present, on that particular kidney, the pedicle which is having the renal artery and renal blood vessels, that is being clipped, and the other kidney is removed out of the body. So 4 to 5 weeks after this clipping, the BP is measured, that is basically the pre-drug administration BP, and then the test drug is given and BP is measured after 2 hours. So basically in one kidney, one clip method, the clip is not removed even after 4 to 5 weeks, and here the blood pressure is rising because of the reason that is when the blood flow to the kidney is less, it is causing renal ischemia, and as a result this stimulates the sympathetic system which is responsible for increasing the blood pressure, that is chronic hypertension. Whereas here we will not get the acute hypertension which we have seen in the Goldblatt model, because there the increased production of renin occurs, here also increased production of renin occurs, but there we were doing the unclipping, basically that is we were removing the clip, and so that time the renin was releasing and it will lead to sudden increase in the blood pressure. But here the renin which is being produced will not be released because the kidney because the clip is still kept in that place. So this is the same with the one kidney one clip model and the two kidney two clip model. So in both these methods we are not removing the clips. Then we have the two kidney two clip method for chronic hypertension. Here spragularly rats of 300 gram in weight is taken, and here the constriction of both the renal arteries or directly the aorta is done with the U-shaped silver clip. Rest all things remains the same. So here instead of actually clipping both the renal arteries, we can directly clip the aorta from which the renal artery is actually arising. Next model we are having neurogenic hypertension. So it is basically based on the sino-aortic receptors. As you can see here, we are having aortic baroreceptors and here we are having carotid baroreceptors. So denervation of sino-aortic baroreceptors is the neurogenic model of hypertension which is most commonly used. So what we are going to do here is we will take the rats and we will do pithing. Pithing basically means to insert a steel rod. Okay, so here we are going to insert a steel rod which is 2.2 mm in diameter and 11 centimeter in length through the orbit and foramen magnum down the whole length of spinal canal of the rat which we are taking, that is the male vista rats. Here we are taking the male vista rats. So as a result, what will happen? The neurogenic control on the blood pressure will be lost, basically the inhibitory control. So as a result, we know that there is now no supply to these baroreceptors. So if there is increase in the blood pressure within the arteries, the baroreceptors will not sense it. So there will be no inhibitory control in the blood pressure, and as a result there will be increase in the blood pressure. That is 30 minutes after pithing to carotid artery, the BP is recorded. So it is basically going to be an increase in the blood pressure. Then what we are going to do is we are going to obtain the dose response curves after giving phenylephrine, which is a selective alpha-1 agonist, so it causes vasoconstriction leading to increase in the blood pressure. Then we can give BHT 920, a selective alpha-2 agonist, by IV. And then what we are going to do is we are going to give the test drug, that is which we are thinking is going to be an antihypertensive, by IV, and again the agonist is being given and it is going to show the curves. That is basically this process is being done 50 minutes later. That is first only agonist we are going to give. Okay. Then after that agonist also is given. Along with agonist we are giving the test drug also. This is done 15 minutes after the first thing. And now we are going to find the curve of BP response to agonist. So definitely now the BP will be decreasing because we are using antihypertensive treatment. And now what is the thing? We are going to compare this pre-BP and the post-drug BP to check the antihypertensive efficacy of the drug. Now let's discuss about the dietary hypertension. So presence of oxidative stress and inactivation of nitric oxide in rats maintained on high fat diet or high sugar diet may contribute to the development of hypertension by enhanced generation of reactive oxygen species. So what does it state? Basically oxidative stress and inactivation of nitric oxide. Both these things can lead to the development of the reactive oxygen species which causes vascular damage, and it is occurring if the individual, that is if the rat is basically on high fat and high sugar diet. So this will induce hypertension by causing the vascular damage. So that's why we are having two different methods under dietary hypertension model, that is fructose induced hypertension in rats, and then we have increased salt induced hypertension in rats. So in fructose-induced hypertension in rats, what we are going to do? We start rats that is 200 to 250 gram in weight are housed per cage on a 12-hour light and dark cycle, that is 12-hour light and 12-hour dark, and they are fed water and chow diet ad libitum. Ad libitum means as much they want to take the food, that is based on their own will. Okay, then drinking water consists of 10% fructose solution here. So here we are giving the fructose in the form of 10% fructose in the drinking water, and then we are going to monitor the fluid intake, food intake, and body weight of each of the rat at every week. Systolic blood pressure and pulse rate is measured using the tail cuff method. That is, once the BP is raised, then we are going to give the antihypertensives, and then we have to check how much blood pressure is being decreased. Next, similarly like this, we are going to do chronic ingestion of excess salt for that particular rat, and as a result this will induce hypertension in the rats. So here what we are going to do is we are going to take Vista rats 200 to 250 gram in weight, and they are fed chow diet ad libitum again as much as they want, and drinking water is replaced by 1 to 2% sodium chloride, so basically increasing the salt content, and this solution is being given to them for the next 9 to 12 months. And again similarly in fructose induced hypertension in rats, here also we are going to measure the fluid intake, then food intake and body weight at every week, and systolic blood pressure and pulse rate is measured using the tail cuff method. So what is the tail cuff method? Tail cuff method is basically to apply the cuff around the tail of the rats. It is basically very much similar to sphygmomanometer, which is used in human beings. So I will be discussing what is the tail cuff method in the upcoming slides. So in both these methods of dietary hypertension, we are actually giving the fructose in first one, that is 10% fructose is given in the drinking water, and as a result it induces hypertension. In the other one, we are replacing the drinking water with 1 to 2% sodium chloride, that is basically giving excessive salt. This also induces hypertension, and then we are giving the antihypertensive and comparing the pre-drug and the post-drug blood pressure. Next we have the endocrine hypertension. Okay, so Cellier et al. First demonstrated deoxycorticosterone acetate, that is DOCA, which is basically a mineralocorticoid, that it causes reabsorption of salt and water, leading to increase in the blood volume and hence increase in blood pressure in rats. So it is responsible for causing hypertension. So this can be used for generating or producing hypertension in the rats. So what we are going to do is we are going to take DOCA 20 milligram per kg, and it is dissolved in olive oil and is injected subcutaneously to the rat twice weekly for 4 weeks, and the drinking water is being replaced with 1% NaCl solution. So as a result, here we are using both the things, that is dietary method also we are going to give NaCl also, then we are also going to give a mineralocorticoid which is causing sodium and water retention, plus we are also going to do unilateral nephrectomy also. So since we are doing unilateral nephrectomy, so there will be decreased production of renin. So what it does is it induces low renin form of hypertension in that particular male Sprague-Dawley rats, that is 250 to 300 gram. So here SBP, after this intervention, SBP reaches around 160 to 180 mmHg after 4 weeks of this treatment. But here there will be decreased levels of renin, unlike the other rat models which we have discussed so far, where there is increased production of renin because of what? Because of decreased blood supply to the kidney. But here we are doing nephrectomy, so there will be decreased production of renin, even though there is hypertension, but there will be decreased production of renin. So after this we are going to give the test drug, which is given orally for 1 month, and then BP is measured before and after the administration of the test drug to evaluate the antihypertensive effect. And after this, these rats are going to be sacrificed, and we are going to look for the end organ damage also, which the high blood pressure has caused. So we can find the particular findings, that is we can get particular findings, that is like glomerulosclerosis in kidney, as you can see in this image. So this is basically about the endocrine hypertension. Now coming to the next model, that is the psychogenic hypertension. So it is basically the stress induced hypertension. So repeated exposure to stressful situation may lead to development of persistent hypertension. So the different types of stress which can be given includes emotional stimuli, it can include psychosocial stress, it can include immobilization stress, that is the rat is not at all allowed to move, so this will lead to stress. Then electric stimuli, all these things can lead to the development of hypertension. So basically stress induced hypertension is associated with either normal or suppressed plasma renin activity. So far what we have discussed, that is in endocrine hypertension, when we are removing the kidney, there will be low renin activity. Okay, there is less production of renin, so that is a low renin form of hypertension. Before that, whatever we have discussed, they have high renin levels. Here either the renin levels can be normal or it can be suppressed. So what is an example of this psychogenic hypertension? That is basically air jet stimulation induced hypertension. So air jet stimulation is being provided to the borderline hypertensive rats, that is they're almost hypertensive, and that is they are exposed to the sessions, that is daily sessions of this air jet. Either it can be short session or it can be long session. Short session means 20 minutes of exposure to air jet stimulation, and long session means 120 minutes of exposure to air jet stimulation. So the rats who are exposed to 120 minutes session, they are having significantly higher systolic blood pressure relative to the ones who are exposed to 20 minute session. Okay, and this is seen within 2 weeks, that is within 2 weeks of doing this torture, doing this air jet stimulation to the rats, there is development of hypertension, and then the test compounds are given to check the antihypertensive effect. As simple as that. So first stress is being given, that is in the form of air jet stimulation. It can be of two types. It can be longer duration, that is 120 minutes daily, or it can be a shorter duration, that is 20 minutes daily. Then within 2 weeks there will be development of hypertension because of this stress, and the hypertension will be more in case of the group who are given stress for longer duration, that is 120 minutes, and then we are going to give the antihypertensive to check the antihypertensive efficacy, whether they are able to decrease the blood pressure or not. Now coming to the next variety, that is the genetic hypertension. So under genetic hypertension, we are having two categories, that is dull salt sensitive rats, and we are having spontaneously hypertensive rats, as you can see here. So let's discuss dull salt sensitive rats. So basically these are the rats which are sensitive to a variety of salt, that is dull salt, and when they are given dull salt, they immediately develop hypertension even in small amounts of dull salt. So they develop severe and fatal hypertension when they are fed high salt diets, and they can even develop normal, like it is not that severe, but they will develop hypertension even if the rat is fed normal amounts of salt also. But when they're fed high salt diets, definitely they are going to develop severe and fatal hypertension. So sprague dolly rats 250 to 300 gram in weight are fed high salt diet, and 8% NaCl solution is given instead of drinking water ad libitum, that is at their own will, and the test group rats are administered the drug orally for 1 month, and BP changes are recorded. So after the completion of this experimental duration, animals of both groups, that is the test and the sham control. Test and the sham control means test is the one which is getting the antihypertensive drugs, and the sham control is the one where we are inducing hypertension but we are not going to give any antihypertensive. So they are sacrificed, their hearts are removed, and total cardiac mass is obtained. Weight of the left and right ventricle is measured and compared in between the sham group and the test group. So basically to check the pathological features which have occurred following hypertension and how the hypertensive drug has decreased this progression. Now coming to the next one, that is the spontaneously hypertensive rats. So by breeding a strain of spontaneously hypertensive Vista rat with a female having raised BP, Okamoto and Aoki, they obtained a strain of rats with spontaneous hypertension. So here in these rats, the BP rises at around 5 to 6 weeks of age of that particular rat, and it steadily increases to reach a systolic blood pressure of 180 to 200 mmHg. That is, we don't have to do anything from outside, any intervention like diet, any intervention like renovascular hypertension, any intervention like stress, they will automatically develop hypertension. That is genetically induced hypertension, that is spontaneously hypertensive rats. And then comparisons are being done between the sham rats, that is the untreated rats, and the treated rats, the rats who are given the antihypertensive for which we are doing the screening. And then the BP recordings are measured, and when the experiment is over, then we are going to sacrifice the rats, and we are looking for the presence of end organ damage also. So now coming to the different methods for measuring the BP in rats. Now as you can see here, this is the tail cuff method which I have already mentioned. So tail cuff method in rats is basically an indirect method of measuring BP, because here there is no invasive procedure. So it allows the measurement of BP without doing any surgical procedure, without doing any invasion. So it is widely used in spontaneously hypertensive rats and experimentally induced hypertensive rats. Experimentally induced hypertensive rats includes renovascular induced hypertension, then stress induced hypertension, neurogenic induced hypertension, dietary induced hypertension, endocrine induced hypertension, all those things. So what is the procedure? It is very much similar to the human sphygmomanometer. So what we are going to do is to measure the BP. A tubular cuff, as you can see here, tubular inflatable cuff is placed around the base of the tail of the rat, and it is also having a pulse detector distal to the cuff, okay, position distal to the cuff. So the cuff is being inflated well above the suspected systolic blood pressure in that particular rat, just as it is done in case of human beings, and until the pulse is obliterated, just as we do in case of human beings. Then the pressure in the cuff is slowly released. As the pressure reaches the systolic blood pressure, the pulse reappears again, very much similar to the human beings, and that is being noted. So it is being noted on the polygraph to look for the systolic blood pressure. So this is one method, that is indirect method for measuring the blood pressure. And now we have another method, which is a direct method for measuring blood pressure, that is by using the indwelling catheter. Basically it is an invasive procedure. So the next method is indwelling catheter for measurement of BP in conscious rats. So it allows direct measurement of BP. Here a polyethylene tube is used as a catheter, and one end of this tube is placed in the aorta of the rat, and the other end is projecting out of the neck of the rat, and it is being anchored to the skin of the neck of the rat with the help of silk sutures. And this is being connected to a pressure transducer, so it is going to directly record the blood pressure on a polygraph. So it is more accurate compared to the indirect method, but it is invasive also in nature. So these are the two different methods by which we can measure the blood pressure, that is the indirect method and the direct method. Now let's discuss about the dog models of hypertension, because we have completed the rat models of hypertension. Now we are going to discuss the dog models of hypertension. Under this we are having two varieties. One is chronic renal hypertension and the other one is the neurogenic hypertension. So first let's discuss the chronic renal hypertension, that is dog 8 to 12 kg in weight are anesthetized intravenously with 15 milligram per kg thiopental. Then a midline abdominal incision is made and one kidney is exposed and wrapped in cellophane. Cellophane is basically to cover the kidney, and then after covering the kidney is again replaced back inside the abdomen. And the contralateral kidney is exposed and its renal pedicle, basically which comprises of the renal artery, vein and the ureter, are ligated and the kidney is removed. Basically one kidney is removed, that is nephrectomy is done. And after this, since we are also clipping the renal artery, so it means body will feel that there is a decrease in the blood flow, okay. So after 6 weeks the BP is recorded either by direct tail cuff method or by direct measurement to the carotid artery, that is to the indwelling catheter, and there will be increase in the blood pressure similarly as it was done in case of rat, that is renovascular hypertension. Next we are going to give the test drugs for the 5 days, and then we are going to check for the antihypertensive effect. So very much similar to the renovascular induced hypertension in case of rats. Now we are having neurogenic hypertension in case of the dog model. So the carotid sinus nerves are isolated, ligated and sectioned, and a bilateral vagotomy is performed to induce neurogenic hypertension, basically to remove the neurogenic control, that is inhibitory control on the blood pressure. We are doing this in the anesthetized adult dogs of 10 to 15 kg, and then a bolus of a test compound is administered by IV route, that is basically the antihypertensive drug, in the femoral vein. And heart rate, arterial pressure, left ventricular pressure, Pmax, that is maximum pressure, the change in the pressure with time are monitored for 90 minutes for any change. And this is basically pressure transducer which we are using. So this is basically the pressure transducer, that is Miller micro tip pressure transducer, which will be present in the carotid artery, and as a result it is going to measure the blood pressure. So once the neurogenic control is lost, there will be increase in the blood pressure, then we give the antihypertensive drug, and then we will check the fall in the blood pressure. So all this is being monitored with the help of this Miller microtrip pressure transducer, which is placed in the carotid artery. Now coming to the next thing, that is the monkey model of hypertension. So whenever we are testing renin inhibitors, which is also a class of antihypertensive, renin inhibitors are having high specificity for primate renin, and they cause only weak inhibition of renin in the subprimate species. So for use of renin inhibitors, that is for checking the antihypertensive efficacy of renin inhibitors, we cannot use the most commonly used laboratory animals such as the rats and the dogs. So for this, we have to use monkeys, and one variety of monkey is the marmosets, as you can see here, because they will show a better effect because renin inhibitors are more specific for the primates. So marmosets of 300 to 400 gram are used for this. Catheters are implanted in the femoral artery for measurement of the blood pressure, and after administration of the test compound in the marmoset, which is injected via the lateral vein, that is lateral tail vein, we are going to check the fall in the blood pressure. So it is mainly used for the testing of antihypertensive efficacy in case we are looking for the renin inhibitors, because renin inhibitors are more specific for the primate renins than the subprimate renins. So here we cannot use the rats and dogs for as the suitable model for hypertension. Coming to the next one, that is transgenic models. So this is basically the last model in case of the in vivo models. So here what we are going to do is we are going to do the introduction of the mouse REN2 gene in the rat, and its overexpression occurs. This leads to development of severe hypertension. So two important features of this rat model once the mouse REN2 gene is being introduced is that here the hypertension which occurs is because of the genetic reason, because the mouse REN2 gene is now incorporating with the genome of the rat. It leads to the elevation of the blood pressure leading to hypertension. On the other hand, still, even though it is genetic, there are some other mechanisms also. So exact mechanism of development of hypertension in these transgenic models are still unclear. And also we can use another methods for inducing hypertension genetically, that is we can use the knockout models. Basically here we remove the genes for ANF, that is atrial natriuretic factor and nitric oxide synthase. Why? Because these two, atrial natriuretic factor, what it does is it decreases the blood pressure. Nitric oxide synthase, it decreases the blood pressure. So if we remove this, automatically there will be increase in the blood pressure. So these are the knockout models for inducing hypertension. So either we can introduce mouse REN2 gene, that is what we are going to do. Either we can introduce mouse REN2 gene for inducing hypertension, or we are going to remove genes for ANF or NO synthase. So in both the cases, we are going to induce hypertension genetically. So this is about the transgenic models. Now finally coming to the take home points from today's presentation. So the rats from all the models, that is whatever models we have discussed so far, they will exhibit cardiac hypertrophy as an end organ damage which occurs because of the hypertension, and not all classes of antihypertensives are equally effective in all rat models of hypertension. For example, endothelin receptor antagonists are not effective in spontaneously hypertensive rats but have beneficial effects in DOCA salt model. Means in DOCA salt model, we are going to get better effect of this endothelin receptor antagonist, that is deoxycorticosterone acetate. And also, comprehensive screening must evaluate multiple mechanisms of action. That is, it is going to look for the mechanism of action through the angiotensin converting enzyme, then angiotensin receptor, calcium channels. So all these mechanisms have to be checked for doing a comprehensive screening and development of a drug which is going to act on almost all the mechanisms which is responsible for causing high blood pressure. So this was about the presentation. So these are the references which I have used to prepare the slides. So with this, I would like to end this presentation. So I hope you like the content. If you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.